respected seniors and dear friends. Earlier I posted this video on our group, the Anaesthetist, but my dear colleagues and seniors like Dr. Vivek Gupta sir, Dr. Jayesh and Dr. Dilip C. Parmar told me that if I can put it with some audio and some explanation, then it will be better to understand. That's why I have tried my best to explain what is fast and how it is useful. So today's topic is fast ultrasound in trauma patient. Do anesthetists really need to learn it? Fast is basically for ultrasound examination of trauma patient in ICU and emergency ward. But is useful to anesthetists? This presentation will tell you whether it is helpful to anesthetists or not. So what is FAST? It is focus assessment with sonography for trauma. So it is not detailed sonography, but we are focusing in certain area to find the blood in the abdomen or peritoneal cavity. So if we can find this some fluid in the abdominal cavity, it must be because of some trauma to either organs like liver or spleen, or sometimes mesenteric tear or any vessel trauma. This examination can be completed within 5 minutes. It is very fast. Fast is very fast. That's why we can diagnose the thing very fast and we can take the patient to O2. It has got very good sensitivity of 73 to 99%, a specificity of 94 to 98%, and overall accuracy of 92 to 98%. It has got very good positive predictive value. If you find some fluid in the abdominal cavity, then there are high chance of blood in the abdomen unless some organ is damaged. But negative fast does not rule out any intra-abdominal trauma. But if fast is negative, then you can go for conservative management. So it is helpful, and we can avoid unnecessary CT. Suppose if your patient is in ICU and he or she gets some fluctuation in blood pressure, you can do fast and see whether there is any fresh bleed in the abdomen or not. So you can do repeat fast whenever you want. You don't need to send the patient to CT scan to check the things. So these are what are the strengths and the limitation of the fast. Strengths are: it is rapid. You can after training you can even do within 2 minutes. It is portable. You can take your ultrasound machine to OT or ICU and do it portably there. It is inexpensive. There is very less expense. It is technically simple and easy to train. Study shows that competence can be achieved after 30 studies. As such, I have learned fast from this forum from Dr. Piyush Malik, and then I attended a 2 days workshop at Ahmedabad. It can be performed serially, and we are doing it regularly in the operation theater, and we have detected many positive fast in the operation theater when patient is sent to the OT with some other injuries in emergency without scanning the abdomen. It is useful for guiding triage decisions in trauma patient, but there are certain limitations also. It does not typically identify source of bleeding or detect injuries that do not cause hemoperitoneum. So fast cannot detect injuries other than bleeding in the peritoneum. It requires extensive training to assess parenchymal reliability. It limited in detecting less than 250 cc of intraperitoneal fluid. If blood is more than 250 cc, then you can detect in the fast. In fact, 500 cc is you can easily detect the blood. It is particularly poor at detecting the bowel and mesenteric damage, 44% sensitivity, and it is difficult to assess retroperitoneum. If blood is in the retroperitoneum, you cannot assess with the fast. It is limited by habitat in the obese patient. It is difficult to do fast in the obese patient. With experience you can do it, but if patient has some air in the subcutaneous tissue because of emphysema, subcutaneous emphysema, then you cannot do fast. Can fast replace CT scan? No, it cannot, but it is helpful in certain conditions. Like if patient is unstable and fast is positive, then ship the patient to operation theater. Don't wait for CT. Fast positive, then you have to explore the patient. If patient is stable, low force injury, negative fast, then we can consider observing patient, or we can go for CT. CT should not be attempted in unstable patient with fast positive. If fast is positive, then go for surgery. CT is far more sensitive than fast for detecting and characterizing abdominal injury in the trauma. CT can give you all details. Where is the injury? By injecting contrast, you can see whether from where bleeding is coming. It is a gold standard thing, but fast helps. But there should be not like the death begins with a CT. You ship the patient for to CT scan. A patient is unstable and patient will die during doing CT. So death should not begin with a CT scan. Never send an unstable patient to CT. Fast, however, can be performed during resuscitation. You can perform fast along with resuscitation. Start fluid resuscitation along with fast. Technique. Our goal is to identify blood in the body cavity where it is not supposed to be. Unclotted blood appears black on ultrasound and clotted blood appears gray. We have to use curvilinear probe for detecting any abdominal injury because it goes deep. It has got better penetration but low resolution, but it is helpful in abdominal injury. We have to scan 4 areas. First is the right upper quadrant. There is fluid between liver and right kidney. This is where you can see this is the liver and this is the right kidney, and you can find some fluid here. Then it is positive fast. Subxiphoid, we have to look at the subxiphoid area to look at the heart and any fluid surrounding the heart. If it is there, then there is chances of cardiac trauma. You can see IVC along with this to see the how much is the volume. If patient is hypovolemic, then IVC will be collapsible. Third part is the left upper quadrant. You have to look for the fluid between spleen and kidney. Here this is kidney and this is the spleen and this is the fluid. Here you can see the some fluid with black fluid between kidney and spleen. And fourth is the suprapubic. You have to search for the fluid behind urinary bladder. So we will see it one by one. A right upper quadrant view, we have to place the probe in the mid-axillary line in the lower thorax. It is sagittal view obtained by the placing probe either in the mid-clavicular line or the lower rib cage or below the right costal margin. It may have to move. We have to move. May have to move probe laterally to avoid gas in the hepatic flexure. Air-filled lung creates reflection artifact in which lung appears to be composed of liver pain. Sometimes your lung will look like liver. That is artifact, and we have to scan for black fluid in the potential spaces. Here you can see this is the right kidney and this is the liver. This is the diaphragm. This is normal view. But if you find some fluid in the Morrison pouch, that is the area between liver and right kidney, then it is a positive fast. If it is present, then there is at least 500 ml of blood in the abdominal cavity. We have to search for the source of the blood. It can be confirmed with CT scan, but if patient is unstable, then we should go for CT scan. Subxiphoid view, we have to place the probe below sternum. Probe placed under the xiphoid almost parallel with the skin surface directed toward patient's left shoulder. We have to direct the probe towards the left shoulder. Parasternal view may be used when some subxiphoids unable to be obtained. Consider pneumothorax when unable to obtain images of heart and no apparent reason. If you don't find any images of the heart, then there are chances of pneumothorax. Air is coming in between these two. This is heart, this is right ventricle, left ventricle with the subcostal view, and this is pericardium. This is normal view, but this is fluid in the pericardial space. So there is some injury to the heart, and we have to intervene. Left upper quadrant view. It is most difficult to obtain, but with practice it can be obtained easily. Probe placed parallel with the ribs in the posterior axillary line, and scan for potential spaces between diaphragm and spleen and kidney for free fluid. If you look here, this is spleen, this is left kidney, this is diaphragm, this is normal view, but this is abnormal view. This is the splenic fracture, this is spleen, there is some fluid, this is kidney, and there is fluid in the abdomen. Suprapubic view, we have to look in the pelvis, above the bladder. Entire pelvis should be scanned from top to bottom with transduction in the transverse place, and then side to side with transduction in the sagittal plane. Pouch of Douglas is the most dependent site in the peritoneum. If there is we have to look in the pouch of Douglas for any fluid. If you find some fluid, black fluid in the cavity, then there is some blood. Sometimes there is physiological fluid also, but it is very small amount. First sign of blood is often two small black triangles on either side of the rectum. That is called bow tie sign. Here you can see this is the rectovesical pouch, this is rectum, this is bladder, and there is no free fluid. But here you can see this is bladder and there is lot of fluid between rectum and bladder. So this is positive fast. So these are the four views that is important to find any fluid in the peritoneal cavity. This is a case report we had recently posted on the forum, the Anaesthetist. This was a 30-year male patient with head injury. Patient was shifted to OT because there was bleeding from the brain, and brain was exposed because of tissue, skull and tissue above that part was lost in the injury. So patient was irritable and shifted to OT in urgency. We induced the patient with propofol and rocuronium, and there was rapid fall in the blood pressure after induction of the induction. Patient was young and it was not expected. Blood pressure went down to 50 mm of Hg systolic. We started immediately resuscitation. We give small dose of ephipres also to bring the BP up, but it took a little longer time to blood pressure to come up. We asked the technician to bring the ultrasound machine to OT, and we did the fast. And what we found is this. First we look in. I have placed in the anterior in the subclavicular line. Probe is placed, and now I have started the scanning. Here you will see this is the liver, you can see, and this is the kidney, and you will find blood here. This is the large amount of blood inside between Morrison's pouch. So this is positive fast. So there is definitely some injury inside abdomen. Here you can see this is liver, this is kidney, and this is black blood. There is lot of blood inside peritoneal cavity, and it is positive fast. This is right upper quadrant view, and you can see it beautifully. So this is positive fast, and we have to explore the patient. Then we went for left upper quadrant view. We placed the probe in the posterior axillary line in the left side, and here you can see there is some. This is kidney, this is spleen, and there is some amount of fluid in this area also. Here this is kidney, You can see this is the kidney, and there is some fluid here also. And then we go for the suprapubic view, and we with patient, as patient has head injury, he was given some head up, and we found lots of blood inside pelvis. This is whole blood, and intestine is floating inside the blood filled pelvis. So this is lot of blood in the peritoneum. We asked the neurosurgeon to call the general surgeon, GI surgeon, and he was called for, and we started the surgery with the abdominal surgery and waited for head injury. uh, we did abdominal surgery first, then we went for head injury part, and the patient was resuscitated with 6 unit of RCC, 6 platelet, and 6 FFP. After 48 hour, patient was extubated, and patient was survived. So this is how we can do implement fast in the operation theater. And this is not only case, we have detected many such cases in the operation theater for the fast, for positive fast, and we can help the surgeons to save the life of the patient. So that's how fast is helpful in the operation theater also. And every anesthetist should learn fast, and other things like lung ultrasound, and then echo, then optic optic node diameter, ultrasound for optic node diameter, then other ultrasound modalities also. So this is how it is helpful to all of us, and this helps us to save the life of the patient. Thank you all. Thank you very much.